Bipolar affective disorder. This consists of recurrent episodes of mania and depression. Episodes of elevated mood are called mania if they are severe and have psychotic features, delusions and hallucinations. Less severe cases are labeled hypomania. Minimum duration of symptoms is 4 days. Etiology and psychopathology. There is a concordance rate of about 75% in monozygotic twins and about 54% in dizygotic twins. A cyclothymic personality is a predisposing factor, i.e. someone who is prone to spontaneous, subclinical mood fluctuations. Mania might be secondary to the following: antidepressant treatment, head injury, stroke, amphetamine or cocaine use, exogenous steroids. Epidemiology. The lifetime risk of mania is 0.6 to 1%. The mean age of onset is 30. The incidence is the same in men and women. The age of onset of bipolar disorder is earlier than in depressive disorder. Clinical presentation. Mania is characterized by the following: sustained elevation of mood or irritability, abundant energy, disinhibition, reckless behavior with extravagant spending, fast driving and promiscuity, pressure of speech, increased self-esteem, grandiose and self-important ideas, sometimes a sense of special mission, acceleration of thinking and flight of ideas, reduced need for sleep, poor concentration, distractibility, lack of insight, sometimes delusions of grandeur, auditory hallucinations in the second person, i.e. talking to the patient. NB. Mixed affective states, i.e. concurrent depression and manic symptoms, can occur in at least 16% of bipolar patients, usually while the mood is shifting between poles. Schizoaffective disorder. This diagnostic category is used for manic or depressive symptoms and schizophrenic symptoms occurring concurrently or within a few days of each other. Rapid cycling bipolar affective disorder. This is uncommon. There are more than 4 episodes of severe depression or mania in a year. It is more common in women and in those taking antidepressants. Differential diagnosis. Differential diagnosis of hypomania and mania in bipolar disorder is as follows: drug-induced overactivity and euphoria, amphetamines, cocaine, and ecstasy. Organic states, hypothyroidism, surprisingly, HIV, general paralysis of the insane and multiple sclerosis. Treatment. Atypical antipsychotics, e.g. olanzapine, risperidone, and quizapine. Valproate, lithium, and carbamazepine. Rarely, and paradoxically, electroconvulsive therapy. Benzodiazepines may be useful to control agitation in the short term. NB. For mania, admission to hospital, which is compulsory if necessary, is usually indicated to prevent personal and social damage due to frenetic and reckless behavior. Hypomania might be contained at home provided the patient can be supervised and is prepared to take regular medication. NB. Watch for severe depressive downswing with risk of suicide. Prophylaxis. Lithium is indicated after 2 severe episodes within 2 years. Check renal and thyroid function, and an ECG because of the risk of cardiac dysrhythmias in older patients. Monitor serum lithium, aiming for a level of 0.6 to 1.0 mol/L. Watch for hypothyroidism, treat with L-thyroxine, and nephrogenic diabetes insipidus. Complications. Risk of death from suicide in a depressive phase. Risk of death from exhaustion after weeks of untreated mania. Manic stupor. Prognosis. Untreated episodes might last between 3 and 6 months. Over 50% of sufferers will have further episodes if the disorder begins before the age of 30.